thank you everybody for joining us. Obviously this is not exactly the way we would ideally like to be doing this conference, but it's really heartening to see how many people have been able to join us. And I'm looking at the delegates list. There's people from all across the country, so you're all very welcome. The sun is shining in Whitley Bay as it always does. So if you happen to live outside the Northeast, then feel free to move here and start working here. You'll be very welcome. Now, this obviously, because of COVID, is not the way we would ideally be choosing to do this conference. And I think it's probably fair to say COVID has been the biggest healthcare challenge that any of us will have to face in any of our lifetimes. And it's been distressing, it's been emotionally challenging, it's been personally and professionally difficult for many of us. We've lost loved ones, we've lost friends, and we've been working in situations that we never could have imagined. And some of those scars will take a long time to heal. But I think at the same time, we've been part of the greatest healthcare system in the world, and all of us in pharmacy as a profession has played our part in helping the country respond, whether that's been on the front counter of community pharmacy, in a hospital admissions unit or an intensive care unit, or adapting to virtual consultations in primary care, or enabling all the many rapid changes in the system we've seen. We've all done our bit, and for that I think we can all be extremely proud of ourselves. I think to me a session like this afternoon represents a small shift back to the norm, in inverted commas, giving ourselves the space and time to think about research, collaboration, reflecting on the way we do things. So I'm very much looking forward to the agenda. It's the first time we've done an event like this, so please forgive any teething troubles. We are in uncharted territory here. So after the event, you'll all be getting an email asking for feedback, whether that's on the format, the platform we're using, the content, or the sessions themselves. We've already had one challenge this morning on the lack of BAME representation in the speakers list, which I think is entirely fair, and the organising group have resolved to look at that for future sessions. We need to make sure that not only are the speakers representative, but we're offering a platform to pharmacy professionals of all backgrounds. So along with that, we'd be very grateful for any feedback you've got in any aspect of the event. I did have my haircut specially for it, so comments on that would be welcomed, of course. So please do respond to that request when it comes into you. The theme of this conference today is about working together, and that's something I've seen so much more of since the outbreak. There's been so much fantastic collaboration, mutual aid, breaking down of barriers at all sorts of levels, and that is a lot of local stuff, but also at national levels, been regulatory breakdown of barriers at regulatory and interorganizational. There's a real desire to capitalize on this and to continue this newfound freedom we've got in the future, and I'm sure that will be a theme that runs through many of the speakers' sessions. If we can have the next slide, please. But before we get on to the agenda proper, I'd like to take just a little minute to mention the recent passing of Dr. Paul Franklin, who I'm sure many of you in the Northeast will have known, who sadly passed away recently. Paul was a lecturer at the University of Sunderland who I met when I was doing my postgraduate masters, where he was my project supervisor. I'm from a lecturing trip to Hong Kong University, where he used his specialist knowledge to direct me to all the best bars and night markets. He knew the place like the back of his hand. I think it's probably fair to say Paul will have influenced many people in the Northeast Pharmacy community. And so everyone involved in the Great North Pharmacy Research Collaborative would like to pass on their thoughts and condolences to his family, friends and colleagues. Next slide, please. Okay, so this is the housekeeping. Obviously, we're all getting more and more familiar with these types of events now. So obviously, if we can make sure that microphones are muted other than the people that are speaking. The way we're going to run it is we want to encourage lots and lots of questions, but what we'd like to say is if you can add them to the chat box throughout the session, then what we're going to do is we'll have questions specifically after the first two sessions, which are the pre-reg project presentations. We'll have questions specifically on those, but after that, for all the other speakers, what we'll do is we'll try and collate all the questions and pick out themes and come back at the end. We've got a brief Q&A session at the end, but please don't wait until the end to ask those questions. Put them in as people are talking all the way through the sessions. Something that I think has worked really well in a lot of these online events has been the development of almost sort of conversations taking place in the side through the chat box. So we absolutely encourage that. speaker presentations are going to be circulated following the event, so you don't need to take notes because they will all be available, and it's also going to be recorded and shared, so you'll be able to get a copy of not just what was on the slides, but what was actually said. As always, we would encourage you to join the conversation on social media, so we have a hashtag, so it's hashtag GNPRC2020, which is very catchy. I'm sure that'll be trending by the end of the day, and there's a link there for further event information. So if we can get on to the main event of the day, we're trying to squeeze quite a lot into 2 hours. So forgive me if I move through the speakers fairly quickly. I don't want to interject too much in between times. We want to get as much value into this time as possible. And that's why we're doing the questions in the way that we are. So our first 2 presentations are from the winner and the runner-up of the annual pre-reg project competition. I'm delighted to tell them, because I don't think they know yet, but I'm delighted to be telling them that there are going to be some prizes on the way to them very soon. The prizes will be coming by email, but they can be exchanged for real monetary goods at the end of the day. So that's great news. We will do brief questions at the end of these presentations. So again, that's a very squeaky door, isn't it? So again, if people can just put their questions in the chat box as we're going through, then I'll pick them up again. Now, the first speaker that we have is Sophia Martins from Gateshead Health NHS Foundation Trust. She's presenting our project on reducing the healthcare carbon footprint by increasing the uptake of salbutamol dry powder inhalers, a quality improvement project. So, Sophia, it's over to you.
Thank you. Yeah, so for my project, I did a quality improvement study looking at reducing our carbon footprint by increasing our use of salbutamol dry powder inhalers. Next slide, please. So the problem with metered dose inhalers is that they contain hydrofluorocarbons as propellants, which are potent greenhouse gases. So because of this, they contribute to nearly 1 million tons of carbon dioxide equivalent emissions per year. So in 2017, we found that 94% of short-acting beta agonist inhalers, prescriptions, so for reliever inhalers, in the UK, sorry, that was 94% in the UK, making it the most prescribed MDI in the UK. So we've got the highest use of MDI across Europe, and it was found that 70% of all inhalers sold in England were for MDIs. So in comparison, Sweden has the lowest usage of MDIs at just 13%. So the NHS is looking at tackling this by the clinically appropriate prescribing of lower greenhouse gas emitting inhalers. So what they mean by this is inhalers which have less propellant, such as the Salamol MDI inhalers, but ideally inhalers that don't have any propellant, which are the dry powder inhalers, so such as Easyhalers. If we're able to do this, we could lower the NHS's total carbon footprint by 4%. Next slide, please. So Easyhalers were the dry powder salbutamol inhaler that I focused on for my project. So they don't contain any propellant, which means that they've got a much lower carbon footprint than MDIs. Patients find them easier to use because they don't need to coordinate the pressing of the button to release the propellant and breathing at the same time. They also have a dose counter, which is great for reducing waste, as they're less likely to be thrown away when there's still doses left. But equally, patients don't continue using an empty inhaler. And at our hospital, we give out air chambers to patients on MDIs when they're on the respiratory ward. So these inhalers are cheaper when we consider the price of an air chamber. Next slide, please. So the aims and objectives were to increase the number of salbutamol dry powder inhalers prescribed in hospital, and in particular, we focused on the Easyhaler, and through this to improve patient outcomes. And at the same time, reducing the number of salbutamol MDIs prescribed to reduce waste. So we started by liaising with the respiratory nurse to form a shared agreement. And then we had weekday reports generated with the number of salbutamol inhalers prescribed across the hospital and the type of inhaler that they were. We then added salbutamol easy healers to the Ward 9 Omnicells. So Ward 9 is our respiratory ward, and the Omnicells are just our electronic drug cabinets. And then following this, we received some feedback from the nurses, and this is that we needed to have more educational interventions, as there was a lack of knowledge on the difference between the Salamol MDI inhalers they were used to and the new easy inhalers on the wards. So from this, I generated some posters to give out. Next slide, please. So this is just a copy of what I distributed. So it's got the flow chart from the NICE guidance of the decision-making tool. And I also just included on the right some of the advantages of the dry powder inhalers. So not only are they better for the environment, but there are also studies have shown that there's fewer exacerbations amongst patients who have DPIs. Next slide, please. So following this, we added easy healers to the priority list on JAC, so our electronic prescribing system. And this was because we found that a lot of the times these inhalers weren't being prescribed correctly. Following this, I held a teaching session on the ward with some of the doctors. And again, I just used some salbutamol easy healer placebos to just highlight the differences and why we were doing this project. Next slide, please. Okay, so here were my results. So on the top, we've got the percentage of salbutamol MDIs prescribed on the respiratory ward, and along the bottom, the percentage of DPIs. So we found that at the start, when we added the easy healers to the ward, not much actually happened, which was quite disheartening. However, once we started with the educational interventions, we started seeing the numbers of these inhalers, dry powder inhalers, come up. Next slide, please. So here were the results over the 3 months that we collected data. And we found that there was a 14% drop in salbutamol MDIs prescribed and an increase of 18% in the dry powder inhalers prescribed. Oh, thank you. So throughout the duration of the study, 55 salbutamol easy healers were issued from pharmacy. So this was 6 times more than in the previous quarter and a saving of up to 571 kilograms of carbon dioxide equivalent emissions, which is about the same as driving 1,400 miles. So this was in comparison to if we had been using the Salamol MDI inhalers, which are the ones we have at the QE. But if we were to use Ventolin inhalers instead, this number would be about 3 times bigger, as they've got much more propellant than the Salamol inhalers. So limitations of the study. So one of the main limitations was ensuring that these inhalers were prescribed correctly. We found that there were many times where patients would come in on easy inhalers, but then be put on salbutamol MDIs, or sometimes they were accidentally put on easy breathe instead. It was also difficult to gauge patient opinion on these inhalers due to the restrictions from the pandemic. But the patients that I did speak to at the start did really like these inhalers and found them much easier to use. And lastly, it was difficult to, sorry, what was that last slide, please? Thank you. Difficult to measure the number of patients switched in hospital and whether the switch had been appropriate. So in conclusion, we found that there was an uptake of salbutamol easy inhalers since the start of the study, positive increase. We found that education appeared to have been the most effective at increasing easy inhaler prescribing rates. And one of the biggest barriers to ensuring these easy inhalers were prescribed correctly, one of the biggest barriers was ensuring these were prescribed correctly on JAC. So future aims. So in the future, it would be nice to have an inhaler recycling point at the hospital. So this is something I tried to do at the start, but at the time, the GSK who do it were oversubscribed. It would also be a good idea to add these easy inhalers to other ward omni cells, so such as the admission wards who see a lot of exacerbations. We could also use Trace to target patients, which is another system who would be able to tell us who we've dispensed these inhalers to. And I think most importantly, we need to continue that these inhalers are prescribed correctly when we do the medicines reconciliation process. Thank you. Does anyone have any questions?
Excellent, thank you, Sophia. Right, there's a few questions that have come in. First one is from Gemma Donovan. Did you incorporate inspiratory flow measurement as part of the switch or prescribing process, and is this important for easy inhalers? And there was another question that came in that was similar about, do you think this is something that should be a blanket switch, or is this something that should be personalized on an individual patient level?
Yeah, so no, we didn't use the inspiratory devices, but it is definitely important to take into account whether patients can actually use the dry powder inhalers. So I had this discussion with the respiratory nurses, and they said that with these newer devices, such as easy inhalers, they are quite easy to use, and there'll only be a small number of patients who won't have the capability to breathe in hard enough. So for the most patients, they should be able to use it, but it shouldn't just be a blanket switch.
Sorry, Sophia, I asked you a big long question there. I was on mute. Apologies for that. I'll make it shorter the second time round. Do you think that there could be some work done on undergraduate teaching and incorporating climate issues such as the carbon footprint of the medicines that are being used?
Yeah, I think that actually be a really good idea. I think it's really topical and it's really in the news at the moment. And I think it is something really important to consider, because I think deep MDIs have just been the standard for so long that people don't really think about it when they're prescribing it. So I think if dry powder inhalers were in people's minds at the point of prescribing, then doctors and prescribers would be much more likely to go for that option instead.
Excellent, thank you. Well, those are the main questions. That you'll be pleased to know, Sophia, A, that that's you finished, and B, that there's an awful lot of very positive feedback in the chat box for you. So thank you very much for that. The second presentation is from Agni Kurati, who's the runner-up of the pre-reg project presentation, and Agni is going to be discussing pharmacogenomic considerations of medicines used in Northern Centre for Cancer Care.
Oh, hello. Can everyone hear me?
Yep, we can hear you. Thank you.
Hiya, so I'm Agna. I work for the Newcastle upon Tyne NHS Foundation Trust, and my supervisor for this project was Emma Groves, and we were looking into the pharmacogenomic considerations of medicines used in Northern Centre for Cancer Care, or NCC for short. So in short, pharmacogenomics is just the study of how genes affect an individual person's response to medications. So it can be used to improve patient safety and help choose the appropriate therapies and avoid ineffective treatments or treatments that might cause harm to patients. And our project built on the fact that the NHS has funded something called the 100,000 Genomes Project, which ran from 2012 to 2018. And the purpose of this project was to sequence the genomes of people with cancer and other rare diseases. And understanding of the genetics of these patients could lead to new emerging treatments and diagnosis methods. And after the success of this project, the ambition is to sequence 5 million more genomes in the next 5 years in order to be able to improve patients' treatments and outcomes. Next slide, please. So my project in particular, the purpose of it was to assess the proportion of medications that are currently used in Northern Center for Cancer Care that have pharmacogenomic considerations. Next slide, please. So in our method, it shows 3 different wards on NCC, wards 33, 34, and 35. And all of these wards were cancer wards. And the way that we chose our patients was anyone that was admitted within a random 24-hour period were included in the project. And we just analyzed the medications that were prescribed within this time period. And the different guidelines that we were using to analyze these medications were the Clinical Pharmacogenetics Implementation Consortium Guidelines, or CPIC for short. And these are guidelines that are used in America when making clinical decisions in patient treatments. And the other guidelines that we were using were the Dutch Pharmacogenetics Working Group, or DPWG for short. And what we did is essentially got the same medication list that we've collected from all of the patients, and we saw the proportion of medications that were included in the CPIC guidelines and in the DPWG guidelines, and we've compared the percentages of medications that were within them. Next slide, please. Oh, hello, next slide. Oh, back. Oh, can you go back, please?
Which slide is it you're looking for, Agna?
It's a result slide with the percentages of medications that were prescribed that had actionable and not actionable. Yeah, that. Yep. Yeah, thank you. So in my project, a total of 61 patients were included, and they all had a median of 13 medications prescribed per patient. So what we've found is that the total percentage of medicines that had gene-drug interactions were 31% for CPIC guidelines and 11% for the DPWG guidelines. So we can see that there's quite a big difference in these numbers, but when you actually just consider the medications that have any type of clinically actionable gene-drug interaction, this number drops to 14% for the CPIC guideline and 9% for the DPWG guideline. So next slide, please. Yeah, so these are the top 10 medications that we found were prescribed within each of the guidelines. So for CPIC guidelines, we can see that metoclopramide is the highest prescribed medication within those guidelines. And I've highlighted which medications would require clinical action in red. And that just means that they would require a dose adjustment or just intense monitoring to ensure that the patients aren't going into any type of toxicity or anything like that. So for example, for metoclopramide, it was categorized in the CPIC guidelines as category D, which means that there is insufficient evidence to suggest that it needs to have any type of clinical action. And we can also see between the guidelines that the DPWG guidelines had a lot more medications that had clinically actionable gene-drug interactions. And a good example of this would be codeine. And because codeine is metabolized by the CYP2D6 enzyme, which converts it from codeine to morphine, there actually have been documented cases of people that carry more than 2 copies of this enzyme gene that they have gone into fatal opioid toxicity. So it is quite important to, it's potentially a thing that's quite important to consider in the future if you were to have the person's genome there. Next slide, please. So, isn't there another slide before that with the graphs? No. It has like a bar chart. To be fair, it should be like a slide with a bar chart, a graph.
No, that's just.
Is it possible to just take it from that one, Agni?
Yeah, it should be okay. Yeah. So just to give people an example of the types of clinical actions that have been suggested by each one of the guidelines. So voriconazole was included in both guidelines, and both guidelines suggested clinical action to be taken for it. So its metabolism is dependent on the CYP2C19 enzymes in the liver, and the CPIC guidelines actually have recommend for people to have a pretest before being prescribed voriconazole, and unless the test results are available, they should use an alternative agent if possible. And after they've been tested, the patient can have the genetics for something called an ultra-rapid metabolizer, which basically means that they metabolize. It increases the conversion of voriconazole, which can increase its blood levels. So they recommend that if someone has these types of genes, that an alternative medication should be used that's not dependent on CYP2C19 and metabolism. So, sorry? No. Sorry. Whereas the DPWG guidelines suggest that if someone is an ultra-rapid metabolizer of voriconazole, oh, sorry, it's the other way around. So it would increase the ineffectiveness of the drug. Sorry. Because the risk of it's highly likely to be ineffective when a person is an ultra-rapid metabolizer of the gene. You would use a 1.5 times higher initial dose as per the DPWG guidelines. Whereas if in the CPIC guidelines, if you're something called a poor metabolizer of voriconazole, you would they recommend that you would use an alternative agent, or you would start with a lower initial dose, but you would only do that if it's absolutely necessary. Whereas the DPWG guidelines recommend that if someone is a poor metabolizer of voriconazole, they should start at a 50% lower dose, and the voriconazole blood level should be carefully monitored. Next slide, please. So our conclusions were that roughly 10% of medications would require additional investigations from prescribers and pharmacists, just purely based on the pharmacogenomics. And this project also highlights the variations between the guidelines and a need for a standard practice across the UK if pharmacogenomic, if gene-drug interactions were to be considered in everyday practice. Next slide, please. Next slide. And based on that, we think that the further research that could be done is we need to determine the potential impact that considering gene-drug interactions might have on the healthcare workforce in everyday practice. And this could be done by a survey of prescribers and pharmacists to determine their willingness and impact on the workload when considering gene-drug interactions. Right, and I think that's everything. That's it.
Excellent.
Yeah,
Thank you, Agnes.
Yeah, all right. Thank you very much for listening, everyone.
Thank you.
Does anyone have any questions?
There's a couple that have come through in the chat, Agnes. I think one of them you've kind of answered, which is one from Gemma about was there an overlap between the two sets of guidelines, which you've obviously kind of alluded to. How significant was that overlap, or were they completely different?
There was quite a lot of overlap, but at the same time, CPIC guidelines tends to include a lot more theoretical interactions, whereas the DPWG guidelines tend to only include medications that would actually have clinically actionable interactions. So to an extent, they both have a lot of the same medications within them. It's just that the CPIC guidelines includes the theoretical interactions that wouldn't necessarily require clinical action.
Okay, good, excellent. And from Jane, pharmacogenomics is a new concept to many pharmacy professionals. So how can we increase knowledge in this area?
I think it's a matter of just making guidelines and making people aware that certain medications are dependent on the individual person's genomes. So at the moment, we're aware of enzyme inducers and enzyme inhibitors. And some of these concepts are kind of similar, for example, for codeine, where its metabolism is dependent on liver enzymes. So I feel like we might want to include that just maybe even when teaching in university when teaching in university, or just making people aware that these guidelines exist and certain medications would require dose changes based on a person's genome. But this is quite difficult as well, because not everyone has their genome sequenced. And even the guidelines the CPIC guidelines are a lot more cautious when making recommendations for pre-testing and things like that, whereas the DPWG guidelines would just say change the dose if the person has this gene.
Yeah. And so that leads on to the final question that's there from Ashling Malloy, which is about presumably gene testing is expensive. A patient told me a private psychiatrist quoted, I'll check the zeros there, £1,000 for testing. So is it expensive to get done?
I think it is, but it's just that it's been funded by the NHS for people only with cancer and rare diseases. So I think like everything, having it done privately would be quite hard and would require you to basically pay quite a bit of money for it.
Okay, so some way to go before it becomes routine practice in all settings.
Yeah.
Right, lovely. Thank you very much, Agnes. Much appreciated.
you.
So thank you to both
Great,
Sophie and Agnes. There's I know it's intimidating enough doing these presentations in front of a room full of people who can see you and are staring at you, but even more so doing it online when you can't see the whites of people's eyes. So well done to both of you, and thank you for sharing that excellent work with us. It's a long journey for these projects, so I hope there's some satisfaction in getting through to this point. Please do continue to innovate and strive for improvement in these services, and we look forward to hearing much more from both of you in the future. So their prizes are on the way to you as we speak. Okay, next up we have Dr. Adam Patterson-Rathbone, who's a lecturer in clinical and social pharmacy at Newcastle University, and Adam's going to be talking about how to start your journey into patient-centred research. Adam.
Thanks, Ewan, and really well done to Sophia and Agnes. They were both really good presentations. That kind of, that's the point of this conference, to give pre-reggers an opportunity to really showcase the important work that you do. So as you've heard, I'm Adam. I'm a registered pharmacist. I qualified in 2011 and then did my foundation training in the south of the region at South Tees Trust, and then I did a PhD in Durham kind of by accident, and then moved to the north of the region where I finished my clinical training, did my prescribing at Cumbria healthcare, and then moved back into academia in about 2017 to take on a teaching and research post. And today I was basically asked to just give an overview for kind of newly qualified pharmacists who might be thinking about having a research-oriented career or having research as part of their career, and to try and kind of dispel some of the myths about how you might get involved in research. So I wanted to start by kind of unpicking some of the mysteriousness about research. So some researchers think that what we do is kind of like a special thing that we do. It's only certain people can do research, and you have to do research in a certain way. But actually, I disagree with that kind of ethos. I think research has lots of different forms. So it could be an experimental form or a review where you're doing kind of a bench side experiment, looking at how a drug is dissolved, or is how it has an action on a particular receptor or something like that. You might do research that involves reviewing what's already out there. So if you do a systematic review or a literature review, that would be classed as research, in my opinion. You might do an intervention study where you've got a new product or a new way of doing something. So you roll it out and you see what the impact is. You might do something like a service evaluation, and you might hear maybe people within certain organisations or within research that they kind of look down on service evaluations, but actually service evaluations are an important starting block for answering some of those early questions that we've got. And the same for quality improvement and audit. Some people kind of don't class them as research, but actually they're part of that broad spectrum of inquiry and investigation that answers questions that we don't know the answers to. So really, for me, research is anything that has a question that you're trying to find something out. Do you want to click a couple of times, Sarah, to bring up those? So these are the three institutes that we've got at Newcastle University. So one focuses on preclinical research or bioscience research, and that looks at a little bit like what we've heard already about the pharmacogenomics and looking at how people respond to medications at a kind of cellular or chemical level. There's the Clinical and Translational Research Institute, and that type of research, or that kind of paradigm of research, really looks at how new medications or new practices and new services have an impact. So it looks at establishing the impact or the costs of new innovations. And then the final institute that we have at Newcastle is called the Population Health Sciences Institute. And that institute really looks at what it's like to use medicines and to use or to experience things in the real world. So rather than looking at it from a clinical perspective, just looking at a specific outcome or a key outcome that you might have identified, looking more broadly at what it's like to use services or medicines in your everyday life. Okay, next slide. So how does pharmacy fit into that? You might have to click a couple of times here, Sarah, so you might just click away. So pharmacy to me is about the design, development and supply of medications. So we historically have been involved in the research side of medication development and design by maybe combining two chemicals together and asking what happens if we mix these two chemicals together, what drug do we get or what product do we get? We might have also had research that was, if we put this drug on this cell, how does that work? What happens there? And that would be a kind of bioscience type of research that you might want to do in a lab. Clinical and translational research that you might do as a pharmacist might look at the outcomes of using different medicines. So drug A versus drug B, what works better? And those types of research might include cohort studies, observational studies, randomized control trials, things like that. And basically in those types of studies, you're looking at what the outcomes are between different variables. And if you do that, then you might get questions about, for example, if you decide that drug A is better, and you recommend that and prescribe that routinely, then that's going to become part of the kind of population's experience of using medicines. So the population is going to develop feelings and thoughts about those drugs. So you might then have to do research that asks the population, how do they think about this product? What do they feel when they use this product? Does it give them any experiences that we haven't already captured in our clinical and translational research? And all of those aspects of research feed into what we do as pharmacists as part of our pharmacy practice. So an example of that might be, if you look at something like morphine, you do a lab study where you see that it acts on a mu receptor, and that numbs the ability of a person to feel pain. You then take that into a clinical setting and you compare morphine to other pain relieving strategies, and you identify that actually morphine's much better. It reduces morbidity from conditions that are painful. Great stuff. Let's use it in the clinic. But then actually, when you take that product out of the clinic and you release it to the general population, you need to monitor how the population responds to that product, because they might have side effects that we didn't count for. For example, being sleepy or being sedated, or becoming addicted to those products. And that will influence how we practice pharmacy, because we are the ones who talk to people about the medicines. We are the ones who give the medicines out. So if we know that people are getting addicted to these products, we can change our practice and then control the supply of them or give advice about addiction. Okay, Sarah, if you want to click a few more times. And again, and again, and again. So pharmacy practice can work the opposite way as well. So you can feed into those different paradigms of research. So because you see patients every day in a clinical role or in a patient-facing role, you will pick up what they think and feel about their product, these medicines, and then you might have questions, or you might want to capture their experiences in a more rigorous or robust way. So you might do a piece of research that focuses on how people think and feel. That could then inform a clinical or a translational research project that looks at what the clinical outcomes of that are. So if people are telling you that they don't like using their morphine because it makes them drowsy, we could look at the clinical outcomes of that. That means their pain isn't managed. That means they're less likely to respond to other treatments or accept other treatments. So then we might do a piece of biochemical or bioscience research where we look at ways that we can understand the physiology, pharmacology of that product better. So that both things feed into each other. For me as a pharmacist, I knew that I preferred the kind of patient-centered research, so asking people how they think and what they feel. So for me, that was kind of I was naturally pulled into that kind of paradigm of research. And I think as a junior pharmacist or a newly qualified pharmacist, you've still got enough experience or enough proximity to the experiences of working in a lab, maybe at university or maybe once you've qualified, to be able to think, is that a direction I want to go in? And as pharmacists, you have that opportunity to go and work in a lab and maybe synthesize new compounds, maybe look at new ways of delivering compounds pharmaceutically. Equally, if you're in a clinical role, you have the opportunity to look at data about clinical outcomes and do clinical research easily. But you also have enough communication skills and experience of psychology and sociology and things like that to be able to do the research that looks at how people think and feel. So really, you just need to think carefully about which paradigm you want to get into, and then try and get into it. So the next logical question is what's on your screen now. How do you actually get into research? And this is what a lot of the trainees and a lot of students I work with ask all the time. I'm going to go on to the next slide. And my first piece of advice would be to read everything that you can about the subject that you're interested in. And this, I think sometimes trainees or students who say, I want to get into research, and we say to them, read as much as you can. I think sometimes they think that we're just trying to fob them off. But in reality, that's not what we're trying to do. The reason we want you to read as much as you can about a subject is because you'll be able to see what's already been done around about that subject. So if you've got a question about, I don't know, penicillin allergies and challenging penicillin allergies, if you look at all of the research about how people have studied penicillin allergies, you'll be able to see the different types of methods of data collection, of analysis, different approaches to that phenomenon that you'll be able to use as inspiration for your own piece of research. Okay, so it's not that we're asking you to go away and become an expert on something before you've done the research. We're kind of just asking you to go and see what other people have done so that we can, I won't say copy it, but use it as inspiration for your own piece of research. And that'll add rigor to the piece of research that you do. So if you want to get into research, the first thing I would say is read as much as you can about the subject that you're interested in. So this picture is, for those of you that don't recognize it, is Oliver Twist. So Oliver Twist is an orphan from a Charles Dickens novel. And he was basically an orphan in Victorian England who worked in a workhouse, or lived in a workhouse. And every day after the boys had worked, they were given one bowl of gruel by the schoolmaster, who's this, the fellow in the blue coat. But Oliver, after he'd had his one bowl of gruel, wasn't satisfied. So he went up to the master of the workhouse and he said, "Please, sir, I want some more." And as you can see in this picture, the way people reacted to that wasn't great. So the workmaster kind of pulls a funny face, the maids are kind of shocked, even the other children are shocked at him going to ask for more. And this has a lot to do with research, because when you are doing research, you've got to ask for more all the time. So you need to ask for more time, usually in your post, to be released from clinical duties to maybe do some data collection or do data analysis. You might need to ask for more help from your colleagues to do data collection, to collect data in an audit, or to collect data as part of service evaluation. You might need to ask for more money. And if there's one thing that a junior pharmacist or somebody that's new to research takes away from this, it's Google Pharmacy Research UK, because they have money and they give it out to pharmacists if you want to do research. And you're going to need money to do it. And then you're going to need more money to do more research. So you need to get used to the idea that you're going to have to ask for more. It is awkward, it is difficult, and sometimes people say no, but it's worth asking, because in the end of the story, Oliver gets adopted by a really rich family and has a brilliant life. So you've just got to keep that in mind, that you might be about to be adopted by a rich family and have a great life. So you've got to ask for more. Okay. Next slide. So this picture is about managing your expectations as somebody who's new to research. So when I got involved in research, when I started my PhD, I had this huge idea that Pfizer and AstraZeneca were going to fund this multi-center randomized control trial that was going to revolutionize the way people use medication. And that just doesn't happen. So on day one of your career, on day 1000, it's very unlikely someone's just going to come and give you a massive goldfish tank to use. It's more likely that you're going to have to start with a small fish tank and build up gradually to a bigger one. So just like the fish here, if you start with a small project that's manageable, that you can do within your practice, or within your role. So that might be writing a patient information leaflet and seeing how people respond to that information leaflet. And if you do that well, you might be able to get that published, or you might be able to submit it as an abstract to a conference like this. And what that does is it creates a little point in time, a little timestamp that says you completed a project. So then when you move on to your next project, it might be a little bit bigger. That's going to create another timestamp that you did a bigger project. And you're going to go on and create another timestamp of a little bit bigger project. And those little leaps from smaller projects to bigger projects actually leave a trail of breadcrumbs for people to look at. And that's useful when you are like Oliver and you go and ask for help, or you're going to ask for more money. If people can look at your trajectory, look at the trail of breadcrumbs behind you and say, actually, yeah, this person has potential, this person has trajectory, they're developing their skills each time, so we'll give them enough money to do a bigger project next time. But it's important to remember that you're not just going to be given a huge fish tank, you're going to have to start small and work your way up. Okay, Sarah? So this next motto is borrowed from Nike, and I don't mean to sound kind of aggressive and say just get on with it, because that's not the message I'm trying to get across. What I'm trying to say is that there isn't a kind of magic point in your career or in your life where you will be able to do research. It's not something that, you know, someone's going to wave a wand and say, boom, now you can do research. There are things like approvals that you've got to get from the NHS ethics committees or the research and development services and things like that. But ultimately, no one's going to do this for you. So you have to just be able to get on with it. You have to be self-motivated and be able to think, yeah, I'm just going to do this. Research is quite a kind of lonely at times, because you are the one that's got to be able to just do the work. And although you work with a team, you might have to be the one that stimulates everyone to get going. So you do just have to get on with it and do it. And that would kind of be a piece of advice that I think was given to me. And I think it's important that other people get that advice as well. Okay, Sarah? And then the last piece of advice that I wanted to leave you with for starting your research is that research is a really long process. So just so am I unmuted now? I think I might have been muted slightly there. So this picture is of a long road, and you don't know where the road's going to end. And that's a little bit like research. You start doing a piece of research and you're not entirely sure where you're going to end up. You might end up in the sunny uplands on the right-hand side, where things are great and wonderful, or you might end up in kind of the dark and dreary inner city, where, you know, that's not what you planned and it's not where you wanted to go. What's important about starting this journey is that you do it kind of with your eyes open. It isn't something, you're not going to be able to do this overnight. It's going to take time, and it's going to take a long time to get a project done or to get a piece of research done. It takes even longer to get pieces of research published. So if you are going to have a research career, expect it to be a long haul. Don't expect it to be something that you're going to be able to get done in a couple of weeks over the summer. It is going to be a small kind of chipping away or a small progress down the road of research. There's twists and turns as well on the road. So COVID is a really good example of how nobody expected this bump in the road for research. You know, as researchers, we've had to change the way we do data collection and things like that. So the slower you go down that road, the more you're able to respond to the changes that are unexpected on that journey. And that's all from me. Thanks very much for listening.
Thanks, Adam. That was really interesting. I love that. I'm sure we've heard something about sunlit uplands before, but I can't think where. That was really, really useful. Thank you. So just a reminder to everyone, please carry on adding questions into the chat. We'll pick them all up at the end, rather than having questions after each individual presenter. So thank you for that, Adam. We'll move on to the next session. So following in that theme, this next session comes from Al Green, who's a senior clinical pharmacist at Northumbria Healthcare and who specialises in clinical trials. And Al's going to talk to us a bit about the recovery trial and how that was set up rapidly in the COVID response.
Great, smashing. Thank you. And I'd just like to say well done to the two pre-regs you presented previously. Really good presentations. And Adam, very good. But I'd just like to have a chat with everyone about the recovery trial. So a bit of background for me. I'm a pharmacist, Northumbria Healthcare. I'm relatively new to clinical trials. I started the post in January of this year. Was just sort of getting used to things when COVID sort of kicked off, and the recovery trial, if anyone hasn't come across it, was kind of the first of its kind and very different to other clinical trials that have happened in the past. So I'm just going to talk a little bit about that and how the lessons we've kind of learned from it. So bit of a timeline. So 14th of March, I bumped into our director of R&D, who happens to be a cardiologist, and kind of had a bit of chat about COVID and kind of how pharmacy might get involved and that sort of thing. We had a meeting and thought, and the research nurses were kind of fully intending to be completely redeployed. So they were worried about, are we going to get training on all these systems that we use, and they haven't worked on wards for years and years and years, and kind of we didn't really have an appreciation as to the behemoth that was going to hit us and the kind of the research community's response to that and how massive it was going to be. Fast forward to the 23rd of March, get an email from the R&D team. So we've got this email about this trial. I think we'd like to take part in it. So at this point, I think there was a fair amount of panic and a little bit of swearing. I think there's some research in there, someone about how much swearing happens as to how much a trial changes throughout its time span. But we started to get our act together, and if those of you who haven't worked in clinical trials, this kind of setup process can take weeks, if not months, sometimes to get going. There's a lot of toing and froing, and we wait for this person, we wait for that person to get back to us, and we wait for this resource, and we wait for stock to come in. 4 days later, we actually randomised our first patient, and that was kind of a little bit scary. We were jumping a little bit into the unknown, which is very unlike clinical trials. We're very kind of protocolized and we know exactly what's going to happen. But this was just sort of did it, and similar amount of swearing happening, mainly kind of relief swearing, I think, at that point. But it was those 4 days were a bit of a whirlwind process. So next slide, please. So the process of the trial, kind of fairly normal, what you'd expect from a clinical trial. So you identify potential patients. So that was all patients with COVID coming into the hospital. At the start, it was a trickle, and then towards the end, or the middle, it was a bit of a flood, and we're back to a trickle now, thankfully. So identify potential patients, and because we were running this trial across the whole hospital, we wanted all the patients involved. We got staff in who wouldn't normally take part in research. It's normally very consultant driven, and those people who are research active do most of the work, whereas this we were expecting everyone to get involved, really. So a patient was consented. We don't have any treatments for COVID. Would you like to try one of these? And for those that don't know, the treatments were azithromycin, an antiretroviral, dexamethasone, hydroxychloroquine, or standard care, and there was a few other treatments that we thought we might get but never actually materialised. So yeah, we said to the patients, would you like to take part? And thankfully lots of our patients were brave enough to do so. Those patients were randomised, were given one of those treatments, we didn't know which, before they were randomised, and then we had to prescribe it. So it was protocolised on our EPMA system, and it's not like a normal clinical trial. It was junior doctors, F1s, FIY1s running around doing that on the wards. And we would, from a pharmacy point of view, supply the medication to the patient on a named patient basis. And that a small supply was kept on the wards for kind of out of hours starting of treatment, that sort of thing. So it all sounds relatively straightforward, but next slide, please. So some of the challenges, the goalposts kept moving. So one of our ward clerks helpfully printed out about 500 consent forms when we first said, right, we're going to set up the trial. And I think 3 days later, that consent form changed. So we had to bin all those, or I think I'm still finding them. People got very excited, and people that weren't used to working in research were doing all sorts of things we weren't expecting them to do. So the goalposts kept moving. For example, at the start, you had to be swabbed positive for COVID, and then it came out. We started to realise that the swabs maybe weren't that accurate. So if there was a high clinical suspicion from the treating doctor, we could include people in the trial, that sort of thing. In terms of consent and randomisation, so the consent wasn't too bad. That was fairly standard. But the randomization, so prior to randomization, we were asking doctors to look at people and decide whether any of the arms weren't suitable for patients. So whether it's the lopinavir, ritonavir, has lots of bucket loads of interactions, whether they're going to look at that and identify a patient is on a medication, we maybe wouldn't want them going in that arm, or if someone is type 1 diabetic, we perhaps wouldn't want them going into the dexamethasone arm, that sort of thing. It took a little bit of time and it took a little bit of education. It took real engagement from the pharmacy team, particularly to help with these, because there were medication specific issues. But we got there, and I'll come in a second to how we got there. And then prescribe the treatments are not as straightforward as it sounds. So the trial could be prescribed by any prescriber. We initially thought we'll just get the doctors to it because they're the doctors and they're good at prescribing. It turns out sometimes the doctors aren't as good at prescribing as we want them to be. We made it, we thought, a foolproof system, but we did have some issues. So I ended up doing some prescribing of the clinical trial, which was a bit of a new role. I don't think, well, as a pharmacist, I've never prescribed a clinical trial before, and most pharmacists working in research wouldn't have prescribed clinical trials before. It's very medic-led. So that was something a little bit different, and working out some of the kinks, working with our EPMA team and working with the clinical teams as to what are the problems here, and trying of working it out as we go, which isn't something you like to say you would normally do in clinical trials. And then supplying the medications to the wards. So the treatments for all the arms of recovery were 10 days long or until discharge. So you didn't continue any medication on discharge. And our trust has kind of covers quite a wide geographical area. So patients are moving around. We want to make sure those patients got those drugs as soon as possible. So we're setting up various sites and supplying medication that we wouldn't normally supply, and people like our technicians getting involved in checking of clinical trials and labeling of clinical trials and administering clinical trials on wards, which lots of our staff weren't familiar with. And it was difficult because I think we just had to demystify and say, this isn't a clinical trial like you've ever known. Just give it and we'll see what happens. So next slide, please. So some of the solutions to some of those problems. So it was just education, education, education. So I produced some posters that you can see there, some frequently asked questions that were coming to me, did some teams-based teaching, which was really useful for the pharmacy team and also for some of the medics, speaking to the research nurses because they were really out of their comfort zone. They, like I say, normally take things at a lot slower pace and weren't used to getting calls in the middle of the night and having to assess things. So really upskilling them in some of the things we had to look at. Putting guidelines out, making information easy to access for everyone that needed to. It wasn't just a small clinical trials team that needed that, but we got all the information out there, I think. We randomized a lot of people, and it was a lot of hard work, and I think the whole team, so the clinical pharmacy team, the research team, the EPMA team, were all kind of integral in providing all these resources that you see in front of you and more, just to make it as safe as possible, but also just to get the people into the trial, get that data, and try and find a treatment. So next slide, please. So the results from the trial, I'm sure you've heard. I've never heard of the results from a clinical trial being the first thing on the BBC News for a couple of days. So that was really positive in terms of Matt Hancock approving dexamethasone, which was nice of him, as a treatment, improving survival by about 1/3 in patients requiring oxygen. So that was really, really positive to see. Also, in terms of some of the treatments that we thought were going to provide some benefits, so things like hydroxychloroquine, we proved wasn't particularly useful. The lopinavir, ritonavir wasn't particularly useful. The antiretroviral didn't work and just meant you were more likely to get side effects from it. So it's, from a kind of scientific medical point of view, it's been the fastest recruiting trial in history, probably one of the most important trials in history, and I think other trials can learn a lot from it. In terms of what happened in our trust and what we learned, so I learned that kind of we had a really great team that could really kind of maneuver themselves and step up to the plate. We have since built a really good relationship that perhaps wasn't there with our just wider trust research and development team, which hopefully will be moving forward as we're kicking research back off again, will be really beneficial. And just make everyone's life a little bit easier, because research is so important. And just generally from the kind of pharmacy staff, everyone worked really hard. It was a really stressful time, and people were just so willing to learn and so helpful. And I think it really showed, and was really gratifying to see these results come through in terms of the dexamethasone improving outcomes and survival. It's the first drug to improve survival, and I think that's all kind of down to the work of our pharmacy team, the medics, the nurses, everyone worked together really well, and it just made people a little bit less scared of clinical trials, which I think is a good thing. So I think that's everything. So thank you for listening.
Thanks very much, Al. I think that the last point you made was the one that was on my mind all the way through it, is that it's very easy to be scared of clinical trials.
Yeah,
So
I still am.
yeah. Well, I hope the swearing's reduced anyway.
Well,
or
maybe.
at least it's less loud anyway.
Yeah.
Brilliant. Thanks, Al. Much
Thank you.
appreciated. That was really good. Next up, we've got a double act. Now, obviously, I want to avoid the obvious Ant and Dec comparisons, so we'll go this time with Boris and Rishi. So we've got Tim Donaldson from Cumbria, Northumberland, Tyne and Wear, and Chris Williams from Tees and Wear Valley, who are the respective chief pharmacists of those organisations. They're talking about something that I think is going to be so important, and it's the subject of mental health as a long-lasting effect of COVID, which I think is something we're all probably starting to see the beginnings of and should be aware of. So over to Tim and Chris. Thanks.
Thanks, Ewan. Thanks for the introduction. Thanks for the previous speakers. As far as Boris and Richie is concerned, no thank you. See me later. So this talk attempts to try and cover a lot of ground, and I'd like to try and do that with Chris, a colleague at Tees and Wear Valley. We're going to attempt to predict the future, which is never easy at the best of times. And to outline the impact upon mental health pharmacy services that we anticipate being needed to respond effectively to the pandemic. I think it's important for us all to acknowledge the scale of the impact from coronavirus, so that we can make sure we have the right preparations in place to minimise its effects upon the health of the nation. And I think we need to start by recognising that it is the greatest social emergency since the Second World War, and it is unprecedented. And in fact, sort of unprecedented feels like a sort of flimsy description of what it is. If the economic impact is similar to that of the post-2008 banking crisis, experts have projected we could anticipate another 500,000 people experiencing mental health problems as a result of coronavirus pandemic, with depression being the most common ailment. That said, it's difficult to predict the future, as I've already said. The last serious pandemic we had was the Spanish flu pandemic from 100 years ago, and we have no meaningful data from that time on its impact on mental well-being. So everything we're about to say should be understood to represent an initial estimate based upon previous sort of major national shocks. The pandemic is likely to lead to an increase in mental health, however, and we are starting to see an impact already upon emergency departments, 111, and mental health crisis teams, who are reporting significant increase in attendance or demand for new referrals to mental health specialist services. And we're starting to see emergent evidence coming forward too, due to be published today, in fact, about a sharp increase in suicide amongst young people, particularly those with autism this year. So in terms of impacts, we've got two main types, direct and indirect. We have people who've been who have survived COVID, who've been through intensive care, first of all, to consider. And having been hospitalized with COVID or in intensive care is a frightening experience. A lot of patients will have required oxygen or IV therapy. Some will have had distressing symptoms of delirium, which we're seeing a lot in people with COVID, or altered states of consciousness. And psychiatrists and psychologists have called for those admitted to hospital to become assessed by mental health specialists and checked regularly thereafter for signs of emergent PTSD. In fact, previous research shows that about 20% of those in critical care do suffer significant PTSD during the 12 months after discharge, which is similar to the rates you see for civil wars and humanitarian disasters, and having pre-existing anxiety, depression, or major risk factors following any episode of intensive care. We're also starting to see evidence from China showing patterns of post-traumatic stress in people who are clinically stable but not admitted to ITU, which is also a worry. When we look at health and social care workers, we have to think about things like burnout, which we have defined as an occupational phenomenon being characterized by exhaustion or feeling distance from work colleagues or reduced productivity. And before the pandemic, this was already a risk for many health and social care workers, and that was acknowledged in last year's interim people plan. It's been noted that the coronavirus does put health and care professionals at greater risk of moral injury as well, and that's a concept developed from within military services, and refers to sort of distress that occurs when your moral or ethical code is violated. And this can be caused by either your own actions or your own inactions, which can in turn lead to negative thoughts, and that can contribute to mental health problems afterwards. And we have to think too about the millions of people currently furloughed, who in the short term are okay, but we worry about who they will worry about, whether they have a job to go back to when the scheme ends in October, or for those who are isolated working at home, which means they're unable to take a break sometimes or feel like they cannot step away from work, many of whom are experiencing difficulties in sleeping or feeling stressed. And that's contributing to higher levels of anxiety amongst home workers. And particularly worrying too is the data coming through about people from Black and minority ethnic communities, where we're seeing for those who are admitted to critical care, approximately a third of people admitted to CCU are from BAME communities, and they're accounting for about up to a third of deaths in CCU. And this may have a variety of explanations. Amongst healthcare workers, it could include high levels of representation within the NHS, but whatever the reasons, which we don't fully understand, we know that it disproportionately affects people from BAME communities, and we have to be undertaking risk assessments for healthcare staff and thinking about how we can shield our BAME colleagues from some of the worst effects of the pandemic. And then thinking about indirect effects, we have effects of grief, loss, and bereavement, which you touched on in the introduction. And we know that the experience of grief doesn't necessarily necessitate intervention, but it can sometimes result in complex reactions thereafter. And thinking about the impacts of the crisis, where relatives have had difficulty in attending hospital to visit loved ones who are unwell, that could easily add to that impact. So we talked briefly earlier about the economic impact, and we know from the banking crisis of 2008 that resulted in significant increase in unemployment, with concomitant effects on mental and physical health thereafter, which increased. And in terms of suicide, that started to increase after years of decline. And we know that could happen again unless action is taken to prevent loss of life. And other conditions like diabetes and long-term conditions associated with respiratory illnesses or cardiovascular disease, we know are associated with poor outcomes in COVID-19. And within the northeast and North Cumbria, we know that we've got some of the worst indicators of health outcomes in England, and we can anticipate a proportionally greater effect in this region in, again, both mental and physical health. So all this in the context of a service which is already being outstripped by demand. And in the case of mental health, hasn't been invested in over the years, although we have seen some progress made in that sense in recent past. So thinking about health and inequality, we know from people who took part in a recent Mental Health Foundation survey that many of those who said they were unemployed were worried about debt and having enough food to meet basic needs, and that in turn is associated with a greater burden of mental ill health. And Martin Lewis from Money Saving Experts done some great work on this over the years to support people in that position. So next slide, please. Forecasting, I said earlier, is difficult, but this chart taken from a recent report from the Centre for Mental Health shows two scenarios related to COVID-19. The one on the left is a prediction of impact on what we think of as a single wave of COVID. So you see over time the number of people affected in the purple line indicates those affected in terms of physical health, but then mental health need following on in a delayed and proportional fashion. And this is sometimes referred to as sort of V-shaped curve impact. The chart on the right, however, indicates the anticipated impact of repeated resurgence in the disease, when it's anticipated the mental health impact will grow in a linear fashion. Next slide, please. So again, I touched upon some of these at-risk groups earlier on. We know that the mental health impact of COVID-19 won't be experienced equally, and that those with pre-existing mental health difficulties are going to be affected disproportionately. But this is a bidirectional relationship. We know there's some previous evidence between mental and physical conditions. Those with mental health illnesses are more likely generally to have physical health problems and vice versa. And we know that people with long-term conditions are more likely to have a higher incidence of mental health problems. I touched briefly on social deprivation. The impact upon children is a particular worry. And we know that children in poorer families, when isolated from school and schoolmates, are likely to do worse than those from more affluent backgrounds. There's also a worry about an increased incidence of domestic violence during the lockdown, and there's obviously reasons to be concerned about that, particularly if it involves children. And we also need to remember that emergency measures disproportionately affect women, exposing them to greater danger from domestic violence and reducing their access to external support networks. So it's absolutely vital that we keep women safe and well during this period, and following trauma, they are more likely to suffer from mental health difficulties. And one of the positive developments in the pandemic, I think, is the creation of safe spaces within community pharmacies for victims of domestic abuse. And I think it's particularly pleasing to see that over a quarter of pharmacies have already become involved in that initiative. Next slide, please. So this slide, which I'll touch on only very briefly, comes from a recent survey of patients under the care of my own organisation, which illustrates the impact of the pandemic upon pre-existing mental health problems, where most people have said that their mental health has got a bit worse or much worse as a result of the pandemic. Next slide, please. So what would help? Well, we know that financial safety netting can help, and it's going to be really important going forwards that the government continues to provide a financial safety net for people whose lives are affected by the pandemic. We know that Public Health England need to be providing advice to schools and organisations about trauma-informed approaches. We know that the NHS should be developing a tailored approach to offer mental health support for people with who've received hospital treatment for COVID-19. And we know finally that the NHS needs to prepare for either a V-shaped or a W-shaped impact of the recession and waves of COVID, with additional need for mental health support. Next slide, please. Finally, just to touch on a nice photograph of my own home city of Belfast. On a slightly lighter note, in fact, I grew up just over the Craigantlet Hills that you can see in the background behind Titanic Belfast and Harland and Wolff's famous cranes. So I put this here just to remind us all that from a difficult past can come a brighter future, and that by working in partnership, we can attract investment that can lead to new opportunities to regenerate and renew. And although I'll declare an interest here, it's also a great city to visit during a pandemic, with many excellent restaurants, bars, and a vibrant cultural life, although I'd like to point out that other capital cities are available. Thank you very much. I'll hand over to Chris at that point.
Yeah, so just moving seamlessly on to me. So Tim's talked about the background and the potential mental health impact across the country and across the world. So I'm just going to briefly touch on trying to predict what life might be like in pharmacy and what support you can offer. So as Tim's described, there's going to be an increased demand in mental health support expected. There's a lot of work ongoing to model this, and I suppose describe it a bit less like Al's experience of research being done at pace and a feeling of frenetically trying to catch up, and more like Adam's experience of thinking about this over a much longer period of time, potentially over 5 years. And I think people are going to present at various different stages, and a lot of the work from Greater Manchester following the bombing showed men presented a lot later, healthcare workers presented a lot later that were involved in the case, and it's really thinking about what it's going to be like over a longer period of time. So impact in community pharmacy and primary care is likely to be increased presentations. People needing signposting, needing counselling on various new medications that they're prescribed, but also signposting to talking therapies and local support networks, third sector. And so primary care may have an increased need for role for PCN pharmacists and techs that are developing in supporting medication reviews and helping patients in that environment. And you're going to see increased presentation in acute settings as well. And so the role for a mental health champion, which I know Tim and I are going to be talking to senior pharmacy managers next week about. So there's lots of increased roles I can see for us in this area. Next slide, please. From a point of view of a specialist mental health service, so I think most of the presentations are going to be in primary care, but of course there's going to be increased demand for particularly psychological therapies going forward. So in our inpatients, we're already seeing an increased acuity, lots of presentations of patients we haven't seen before. And in the community, I think the biggest challenge for mental health services is going to be to try and increase the pharmacy input into those community teams to get more of a skill mix, releasing time for different approaches and different care, different therapy with the patients, and maximizing what we can do around medicines. Next slide, please. So I've taken it as my approach to support all of our own mental health well-being, as we're running a bit behind, is to fly through my slides a little bit. So just recognizing help's just a phone call away. So I suppose from everyone's point of view, and I know there's a lot of people on this call not from just in the Northeast, is recognizing what you can do to support people around you, recognizing where someone might be suffering themselves, mental health related, and what signposting can you offer? What, are you there just to be able to listen to them talk? But there's some contact numbers there that can be used locally in TUV and CNTW. Next slide, please. And this slide, I think is always best to pinch from someone else. So this slide came out across the NHS during the whole COVID crisis, and there was a lot of support for mental health, self-guided support for health professionals came out. So there's lots of links there, lots of apps that can be used free of charge to NHS workers, plenty of places to go to seek support for yourself and others, and just utilising those signposting opportunities where possible. That's it from me. Thank you.
Excellent. Thanks, Tim and Chris. That was excellent. A fairly sobering presentation there. Obviously, thinking that with COVID is something we're going to be living with for a very, very long time, or the effects of COVID we'll be living with for a very long time. But yeah, just that a really important message at the end there, Chris, that help us out there for us. And this is not just about the wider patient population, but the effect on healthcare professionals who have worked through it as well. So thank you very much to both of you. We'll just move on now to Peter Boyle, who's a graduate from Liverpool Cumbria University, who is due to start his pre-reg here under interesting conditions, I'm sure. And he's going to be talking about differential attainment in pharmacy pre-reg training, selection and registration assessments. Peter.
Hi, everyone, and thank you to Ewan for the introduction. There we go. So as mentioned, my name is Peter, and I've just finished my MPharm course at Liverpool John Moores University, and I'm due to start my pre-reg in August, doing my training at Aintree Hospital in Liverpool. So I've been asked to talk to you today to give a brief overview of my final year project, which was entitled Differential Attainment in Pharmacy Pre-Registration, Training, Selection and Registration Assessments. So that's some background to the project. First of all, what is differential attainment? So differential attainment is defined by the BMA as systematic differences in outcomes when grouping cohorts by protected characteristics and socioeconomic backgrounds. These protected characteristics are defined by the Equality Act 2010 as those listed below, and they include a person's age, race including colour, nationality, and ethnic or national origin. Next slide, please. Thank you. So why differential attainment in pharmacy? So it's been shown that white candidates consistently outperform Black, Asian and minority ethnicity colleagues in the pre-registration assessments. And this has been reported with headlines such as these. and has led the GPHC commissioning research through OPM to undertake some research looking into it. And although far more research needs to be done, as we do lag significantly behind other fields such as the medical field. Okay, next slide, please. So we wanted to take a look at this, and the primary aim of our study was to evaluate outcome data from the 2019 GPHC registration assessment for the presence of differential attainment. So next slide, please. So to do this, we submitted a Freedom of Information request to the GPHC. We requested several years of information worth of data. However, only 2019's cohort was provided, as prior to 2019, the pass list was published and there was concerns about identification of candidates. The 2019 cohort data contained data for 3,782 trainees on a pass-fail basis, combined for both MPharm and OSPAP routes into the pre-reg year, with information on the university attended, the age, the gender, ethnicity, disability status, and the training sector where they spent most of their pre-reg. Okay, so we started the analysis by first looking at pass rates. So as you can see, pass rates by age, there was a trend as pass rates decreased with age. Training sectors also show variation in their pass rates, with hospital placements producing trainees with the highest pass rate in comparison to other sectors. And if you compare pass rates by gender, it shows that females perform more favourably than males, and the much publicised variations in pass rates by ethnicity is clear to see, with white British students having the highest pass rate and those of black or black British African ethnicity having the lowest. However, pass rates can be useful, but they are a very crude analysis and on their own may not be of much use. So if you can pull up the next thing. So this area could represent a student, and these are the variables that influence the probability they're going to pass the exam. Hypothetically, all white British students who have passed the assessment could be from the top performing universities, being the youngest age group, all female, and have trained in hospitals. So how do we know which is a covariable and what the influence of an individual variable is? So we attempted to do this by binary logistic regression. So we used some software, Minitab in this case, to add and remove variables to produce coefficients that are then turned into adjusted odds ratios. And these ratios can predict the probability that someone will pass the assessment in comparison to a dummy or a control variable. For example, the probability that each ethnic group will pass the assessment in comparison to white British applicants. And this gives us a suggestion of the effect each variable has in isolation, removing the confounding effect of all other variables. So we can effectively remove them, finding out the effect of one variable in isolation. So as I mentioned, the odds ratios produced show the probability of passing the assessment in comparison to the control variable. So less than 1 is a smaller probability of passing, 1 is the same probability, and greater than 1 is a higher probability. So I'd like to preface our results here by saying that odds ratios can be difficult to interpret, and an odds ratio of 0.5 compared to 1 does not mean that only half of the students would be expected to pass. And so it's not really in the scope of the presentation to go into it in too much detail, and the take-home message really is whether variations are there and whether they're statistically significant. So from our analysis, we found that statistically significant variables were the university attended, the ethnicity of the students, the age of the students, and the training sector. And non-statistically significant variables were the gender and disability status, although it was only a very small sample size that did declare a disability. So if we take a look at how the university attended may influence the probability of passing, you can see that there is variation. The blue line here represents a control variation, which was the university with the largest cohort to ensure robustness of the data, and this did happen to be a high-performing university. So many of the universities are clustered around the same sort of areas, however, there are statistically significant differences. Okay, so if we take a look at the results relating to ethnicity, we've chosen to include the unadjusted and adjusted odds ratios, as it ensures the importance of including other variables. So prior to adjustment, when ethnicity was not the only variable included in the model, so it was the only variable included in the model, black or black British African applicants have the lowest odds ratio, and with an upper confidence interval of 0.21, which falls below the lower confidence interval of the top 4 performing ethnicities, being 0.22, 0.24, 0.34, and the 1 of the white British control variable, the results are statistically significant. And when we adjust the variables for following the adjustment, there is an increase in the odds ratios for all ethnicities with the exception of Chinese or Chinese British. And these increases show that the data is confounded by other variables. And although the black British African cohort remains the lowest odds ratio, the upper confidence interval falls above the lower interval of all other ethnicities, and therefore the difference is no longer statistically significant. However, that is excluding the white British cohort, which remains a statistically significant difference, showing that there's definitely an attainment gap. So this slide just shows that data in pictorial form. So you can see from the ranges, the upper confidence interval of the black British African cohort falls into the range of the other groups. So if you just click on for me, there's a blue line that will come up. There we go. However, white candidates would be shown here by the red line on the right. So you can see there is quite a gap. And next slide, please. So when you produce a regression model, the software produces a fit value, and the variables we've included only account for less than 17% of variation between individuals. And that just tells us that more data is needed. So an example of this is that when gender was the only variable included in the model, there was a statistically significant effect. However, when it was adjusted for other variables, it wasn't. So that shows us that there is confounding variables. So if the variables we have only account for that 17% shown by the grey area of this pie chart, what accounts for the rest, and what effect would including these other unknown variables have on our data? So what could these variables be? Okay, so research has suggested that language barriers can have an effect on a student's chance of passing the assessment, and we've got no data on numbers of overseas or OSPAP students and no data on the number of students whose first language isn't English. Studies in other fields have shown that white students from disadvantaged backgrounds are equally likely to perform poorly as those from BAME populations, so could it be a socio-economic issue? The OPM research found that family and financial commitments impact heavily upon the pre-registration year, with BAME students more likely to have an extra part-time job, reducing the time to study. Difficulty in building relationships and maintaining relationships from university has been quoted as a reason for that BAME students tend to struggle in the pre-reg year and struggle to adapt and settle in at their new place of work. Research into specialist medical training, where there appears to be a lack of differential attainment, has shown that diversity and support within the workplace is vital with BAME role models key to success. So underrepresentation of BAME students in the hospital sector has led to a belief that these placements may be out of reach. 91% of Oriel students ranking NHS hospitals as their first choice, white British students ranking highest in this process. So far, this serves to increase the representation and the issue. And studies in the medical field have shown that it's not academic ability that's at the root cause of different attainment. Next slide, please. So our conclusion is that there's definitely an attainment gap. However, there's not enough data. We can't fight the problem if we don't have the root cause. Next slide. Thank you. So where do we go from here? So we need more data. We need to utilize the data that we have already collected and collect and make available for analysis new data on variables such as socioeconomic background, primary language, attainment level prior to pre-reg, whether a candidate has come from MPharm or OSPAP routes, and how many attempts an applicant has had at the assessment. This would provide us with more robust evidence of target support towards the problem. We're of course aware of the GDPR issues, and these will have to be overcome, perhaps by local level collection and analysis of granular data and sharing of outcome data for wider analysis. What is clear is that change will require research and support from all involved institutions, in particular Health Education England, the GPHC, the RPS, and higher education institutions. So yeah, next slide. So that's the end of my presentation. Thank you very much for your time and for having me to talk today. And thanks to those who support me through my project and preparation for this presentation. So we'll hang around at the end if anyone has any questions. And if not, if you'd like to email me, that'd be great. So thanks again for having me.
Excellent, thanks, Peter. I normally run a mile from stats, but that was really interesting. I think Jane said in the chat there that you explained the stats really well. Absolutely, I thought that was a fantastic presentation. I think there's plenty in there for us all to reflect on. A lot of learning still to be done in the profession, for the system to be done. So thank you very much for that, and I'm sure you will have people contacting you. Next up, we've got Jane Brown, who's the Pharmacy Dean for the North from the School of Pharmacy and Medicines Optimisation, Health Education England, and she's giving us an update on the pharmacy workforce post-COVID.
Okay, thank you very much for that introduction. Yeah, so I'm Jane Brown, and I'm Pharmacy Dean for Health Education England across the North, and our remit is to support the NHS to build a pharmacy workforce in the right numbers with the right knowledge and skills. So what we've already heard a lot about how pharmacy teams have given a fantastic response to the COVID pandemic. And what I'm going to talk about is what the pharmacy team might look like going forward. I think we need to remember that pharmacy teams are always very person-centred, whether that person is a patient, a carer, or a member of the public walking into a community pharmacy. But what we've definitely seen is much more collaboration between pharmacy teams working at a place-based level across organisational boundaries. We've also seen much better use of digital technology, and I just wanted to remind people of the importance of some of the core skills that underpin that patient-facing clinical pharmacy practice. Next slide, please. So first of all, the collaboration. We've seen fantastic collaboration between organisations as part of the COVID response. In particular, our professional bodies have come together, supporting people changing practice. So the Royal Pharmaceutical Society, the UK Clinical Pharmacists Association have provided fantastic support for critical care pharmacists, particularly those people who don't normally cover critical care wards as part of their normal role. And what we've seen is that pharmacy teams needed to adapt so that they could move into providing good quality patient care for those specialist units. RPS have also worked with the Primary Care Pharmacists Association to support care homes, and we've also seen response from the Association of Pharmacy Technicians as well around a medicines administration framework to support pharmacy technicians to administer medicines to release nursing time for that care that only nurses can provide. We've also had a great response from pharmacy leaders across the whole of England to make sure that we had staff there for those Nightingale hospitals. I'm getting a bit of echo. Is there someone who's not on mute? So yeah, we've seen I'll put my microphone, see if that's better. Anyway, we've seen pharmacy leaders come together to make sure that we've got pharmacy teams there to man the Nightingale hospitals if they were needed for patient care. And we've also seen some of our more strategic organisations such as NHS England and Improvement, CCGs and clinical commissioning support units, and also Health Education England releasing members of their pharmacy teams into frontline services. We've also had great response from our tripartite leadership teams, where we've had collaboration between CCG leads, community pharmacy leaders, and NHS trust leaders as well, to come together to find out what support is currently provided to care homes and make sure that we can provide that care homes response there across the patch. Next slide, please. The next slide. I'll carry on. So the next slide is about digital. The digital transformation has been one of the biggest changes that's been accelerated by COVID.
We've rapidly seen online delivery of training delivered to support our pharmacy technicians, our pre-registration pharmacists and our undergraduate pharmacy students, so that we can actually continue with that pipeline of pharmacy professionals to make sure that people complete their training on time and so can move into the next steps. We've also seen that from other organisations, so RPS, as I've already mentioned, but the Centre for Pharmacy Postgrad Education have quickly moved from face-to-face delivery of training into a virtual environment so that we can keep enhancing pharmacy professionals' knowledge and adapt their skills to this new way of working. This has also enabled us to set up virtual communities of practice. And I think that's really important because when we think about the North Cumbria North East footprint, actually, sometimes it's quite difficult to get together as colleagues. So this has allowed us to meet together virtually, and we can do this across the whole of the country and beyond, really. So that I think that's a really important development. Healthcare itself has changed, so hospital outpatients are no longer being delivered always in a hospital setting, and so what we're seeing is that patients are now having that consultation in their own home, wherever that might be, and certainly some of our general practice pharmacists have been consulting with patients who are in their own homes as well. I think what that brings to us is a different set of challenges, though. You miss some of those visual clues that you would normally get when talking to a patient face to face. You would also miss that perhaps they're not walking quite so well, or that they're struggling with something within their own setting. And so I think it's really important that we do make sure that we're skilled to provide those those virtual consultations, and that we learn from that. I've got a picture of a robot here as well, and I think that was just to remind us that we're not robots, and that actually we still need to bring that human touch into our relationships, both with patients, with the public, but with our other colleagues too. The COVID response, I think, has also accelerated uptake of the electronic prescription service, and that's supported our community pharmacy colleagues, both with the flow of work throughout the pharmacy and also to manage their stocks as well, because people don't want to touch pieces of paper at the moment. Next slide, please. So it's important to recognise the contribution that the less visible core skills have played as part of the COVID response. So we've seen aseptic teams producing ready-to-give injectables to free up nursing time for nursing care on the wards. Our procurement teams have been amazing as well in making sure that we've got a supply of medicines that are available for patient care. And we've already heard from Tim and Chris about the importance of mental health and well-being, and this is going to carry on. So it's really vitally important that all pharmacy professionals have those underpinning mental health and well-being skills. We heard from Agni earlier about genomics, and I'm really pleased that her project was about that, because that is something that is going to accelerate. It's all relatively new, I think, to pharmacy professionals, but it seems to be happening at speed. And so genomics and personalised medicines are something that we really need to start thinking about and putting into our undergrad learning and also postgraduate programmes as well. I'm not really going to talk a huge amount of research because Adam covered it really well, but just to say that I do hope that Peter, Agni and Sophia do carry on with that research journey that they've already started, because anyone who's wanting to develop into an advanced practice or even consultant pharmacist role really needs to have that thread of research going through their whole career. And that can be from clinical trials, as we've seen from Alistair, or it can be just getting involved in audits and service improvement or quality improvement projects. And we need to make sure that we both build the evidence base, but once the evidence base is out there, we actually play our part in implementing it, because we all know that there's plenty of evidence out there that doesn't actually get implemented in practice. I think leadership as well is a core skill, and you don't have to be in a leadership role to demonstrate leadership capabilities. And everyone will have their own definition of what leadership means to them. But I think for me, what it really means is caring that the right thing is done, both for patients and for our colleagues as well. And if something isn't right, doing something about it. Next slide, please. So when we think about what the future holds, so what we want and what we've seen from the response of pharmacy teams to COVID has been that we do have a flexible workforce, and we have that ability to work across organisations, and people have been moving the organisations that they work within as part of this response. And you might end up with a portfolio career where you work perhaps in hospital or community pharmacy and a general practice as well. But even if you don't work across there, we need to start thinking more about training people in different sectors as they move through their pharmacy career, so that they at least have an awareness of their impact on other sectors and what their actions in one sector and how they impact on a different sectors, if we think about hospital and community pharmacy in particular. What we will do as HEE is that we'll make a clear career pathway for pharmacy professionals, and that will go all the way from undergraduate up to consultant level practice for pharmacists, and then for pharmacy technicians from trainee pharmacy technician to advanced pharmacy technician as well. And whilst HEE will provide that support for that progression, we also need everyone to take personal responsibility for developing themselves as well. I also want to see increased visibility of pharmacy. We've heard a lot about the contribution that pharmacy has made, but we do know that people aren't necessarily choosing pharmacy as a career. And so I want everyone to go out there and take pride in being a pharmacy professional and talk to people about how fantastic it is. Because I think actually we do provide a great role, but we need to make young people think about taking on a pharmacy career and choosing science whilst they're earlier on in their school careers. And I think that's a job for all of us to do, really. We need to shout about it a little bit more. And Ewan talked right at the start about breaking down barriers, and I definitely think that we've shown that we can collaborate across pharmacy sectors and work really well together. We can also collaborate much more with our nursing and medical colleagues and other professional colleagues as well. So we need to really shout about how great pharmacy actually is. So just next slide. So I've just put the school website on here. So do go away and have a look at what's on the school website and what's opportunities are there for people who are within pharmacy teams across the north of England. And then my contact details are there as well. Thank you.
Excellent. Thank you, Jane. Much appreciated. I think you're absolutely right. The collaboration has been so heartening, and the way that the pharmacy profession stepped up was absolutely incredible. So there's so many positives to take away from a professional perspective. That was really interesting. Thanks, Jane. We're running a little bit behind time, so I think we do have scheduled in for a Q&A at the end. But I think what we'll do is collate all the questions we get and get them out to all the delegates with a follow-up communication. I'm sure. Speaking on behalf of the speakers, I'm sure the speakers themselves would all be happy to be approached directly about any specific issues as well. So that gives us a little bit more time, just so we don't feel like we're rushing through the last couple of presentations. So next up, we've got Stephanie Klein, who was somebody I personally didn't know until March of this year, but then had the pleasure of working with on the Nightingale Northeast project, which is certainly one of my professional highlights, and I'm sure it was one of Steph's as well. She was a pleasure to work with. So Steph's going to be telling us a bit about that project and what learning we can take away from it. Steph. I assume Steph is still with us.
Can you hear me now?
Yep, we've got you, Steph.
Sorry, I think I got muted. Well, thank you very much, Ewan. Thank you for that that kind introduction, and thank you to all the previous speakers. It's been really interesting to listen to everybody this afternoon. As Ewan said, yeah, this was quite a unique experience, I think, for us all, and was a great opportunity for collaboration and meeting new colleagues from around the region. So yeah, definitely something we'll all remember. What I'm just going to take you through is doing a little bit of scene setting, and then talk a little bit about the pharmacy setup for the hospital. So this is, if you just go through the next slide, please, Sarah. So effectively, this building was designed to be an innovation centre, and it got taken over very much in March to create one of the Nightingale sites, one of 11 across the country. The background behind this was they did modelling ahead of the first peak of COVID, and the figures indicated that we did need more capacity across the country, and certainly in the northeast, it was estimated we'd need about 1,000 additional hospital beds. All the regional leads got together and had a discussion about this and looked at what capacity they had and what surge capacity they could get to by sort of rejigging their current beds and infrastructure. And they came back and thought actually probably more reflective figure would be to have an additional 300 to 500 beds, and that's what we were asked to try and provide. So on behalf of all the trusts in the region, it was decided that Newcastle Hospitals could design and mobilise this work, but very much our brief was to work with the region, and that was a very useful thing to do. So basically, the facility was to be produced and put together in a quick time scale. Nobody really knew what was to come. And if you pop on to the next slide, please. So we went from this, and in 3 weeks we were told that we would have to transform this empty warehouse into the next picture, which is a hospital with 20 wards. And as you can see, we actually managed to achieve it by amazing means, really. So if you pop on to the next slide, what we went from, and there is a time-lapse video, I think, available on YouTube if anybody wants to look through that. I think we've got the link. You can see how that transformation developed from literally an empty space to this 460-bed area. So the ambition always was that we would never, hopefully, not need to open, and because the hospitals in the region are really well structured, and they had, got capacity to take patients. But we had it there just in case it's needed, and any decision was going to be made through the mechanisms of NHS England in conjunction with the North East Surge Command that was set up, which obviously engaged all the chief executives of the local trusts. So you go on to the next slide, please. So really, at the beginning, I was sort of brought in by the chief pharmacist, Neil Watson, at Newcastle Hospitals Trust, and asked to set up the services. So that was quite a challenge. So the first thing we did, if you could go to the next slide, is think about what the clinical model is. What have we got to deal with? What have we got to deliver? And this was sort of like the basic brief we were given. That all the patients that we were going to have would be COVID-19 positive. And that they would be assessed in the sort of feeding hospitals. We would get a 24-hour sort of lead in to bring those patients in. There was quite an extensive exclusion criteria. Because this is essentially a field hospital, there isn't all the technology and the testing that we would need. And as we've learned, certainly with the sort of information that's come out of treating patients as we've gone through, we know that some of the very sick patients have big demands. They need CT scanners because their blood thickens and there's clots, as well as renal support and all of those other things. So very much this hospital was built as somebody's child in the background. It's not mine. That we have, so very much we're focused on providing a space for patients to be treated, but the belief in the region was very much if you were very, very sick and you needed all of that really intensive therapy, that the best place would be back in the acute setting, back in the proper intensive care units, where all of the scanners and renal support could be provided. So the model that we were very much asked to base our services around, our pharmacy services around, was this phased approach that the first patients would come in and occupy a 28-bed ward. And then as things escalated, we would build up our services to match an escalation and filling those wards in that pattern, as you see there through the three phases. So you got the next slide, please. So what we were sort of told in a brief to provide a clinical pharmacy service, medicine supply, very basic, and maybe an on-call supply for clinical crews and that type of thing. So that was sort of the outline brief. Obviously, we had to look at that, and we also had to look at the challenge we had as we went forward to deliver that service. Obviously, the timeline was only 3 weeks. It was very, very short. And to think of turning around a 460-bed hospital in 3 weeks is quite a scary prospect. So we always had that in the back of our minds, that this had to be a quick transformation work. It had to be timely. We had to get on with it. We did have the concerns because the changing clinical model. Nobody really understood what the demand was going to be, whether we were suddenly going to have be overwhelmed in the region and the peak would be sooner than we thought. We still weren't 100% sure whether we would need to have a lot of ventilated patients or patients who didn't need CPAP. They just needed care and support and the more sort of like lower level type. So the model was constantly changing, and we had to be thinking around what medicines, what profile of medicines did we need for those different levels of patients. So obviously an intensive care patient needs a different profile of medicines than sort of like level 1 patient. We had to think about the space we had. We were put into this already sort of like pre-designed facility. The plans had been drawn up. We have 2 medicine stores in the COVID area and 2 preparation areas where we could support medicines preparation, and that was about it for 460-bed hospital. We had 3 rooms outside in the more admin area, and again, that was it. So we had to think, how do we bring the medicines we need to that area, meet the demand for 460 patients if we needed to in a timely fashion. So there was quite a lot of challenges there. The next one was really we work on a building site. So we had a massive construction facilities going on while we were trying to design our services, and working with that and going in and off the site, and hard hats and that type of thing, and also trying to work with the design. So it's a very moving target. So we had to think about what we needed in the rooms, IT points, storage, how the rooms would work, how the workflow would work, how the airlocks would work between the non-COVID area and the COVID areas. So we had to think about a lot of those aspects and work very much with the construction teams as well to make sure that we had everything we felt we needed to provide the pharmacy service that we had in mind. The next one is the demands on medicines and equipment due to the pandemic. I'm sure a lot of people will be aware, there was all of these Nightingale hospitals being constructed across the country. There was already demand within hospitals for set medicines, a pressure on ventilators, number of ventilators. So we also had in our mind that we need to plan to have certain amounts of equipment, but we didn't want to bring equipment or medicines to site that would compromise care in any of the areas. So we always had to think about how we phased our plans and how we would phase bringing medicines in or equipment as we needed it, not to compromise the bigger plan. And obviously through all of this, we had infection prevention control measures that we need to be mindful of. Very much for this facility, we had basically 20 wards constructed in one big warehouse area, and everything in that area effectively was potentially COVID infected. So all of the staff that we put into that area were going to have full PPE, and there was a lot of considerations about how we would structure that work and think about that, and how we would manage the staff, and also educate the staff about how we could work within that structure. Also with regard to infection prevention, we had to think about as we were planning as a team about how we worked to social distance, where we were working with the teams, and also working with all the other multidisciplinary teams that were on site. So there was quite a lot of challenges there. So if just got the next slide, please, Sarah. So what do we really do first? Well, really, we got a few of the sort of like key stakeholders. So we got together and we had a chat, and we thought about really what we thought we wanted to provide and what we could provide, to try and make this, the best service that we could. We were lucky in some aspects. We were the last to the party, and we'd be able to learn from other Excel centres what had gone well and what hadn't gone so well, and also think about what we could provide with the knowledge we had and with the services that we had from or provision from the Newcastle hospitals. So we very much wanted a clinical pharmacy service, medicine supply chain. We wanted to look at the workforce planning, the training and the on-call aspects, and think about the operational hours, and also think about within the workforce and the planning very much how we were going to engage with the regional stakeholders. As Jane said in the previous presentation, that collaboration is very important, and very much we want to make sure that everybody was engaged. We were going to have to, borrow staff from other hospitals in the area. It was very important that those people were engaged and they understood what we were trying to achieve. And we did have some peer review, and we did encourage people to engage with that process. And we had some good people working on that aspect. Informatics was a work stream that we set up. Very much we wanted to have e-record in place and utilise technology as best as we could to manage medicine supply and those aspects. In other Nightingale hospitals, they'd gone for the paper-based approach, but we felt we had an opportunity to use the electronic system, both reducing paper for the infection risk and just to keep records and do better medicines reconciliation and some of the other work that we wanted to do. We had a work stream looking at wanting to look at the opportunity for ready-to-use IVs. Very much we felt that if we ended up being full capacity in this unit, the nursing staff were going to be very stretched. We think about the number of nurses we were thinking about having to pull from the region to support these patients. We very much wanted to minimise their workload in supply and preparation of medicines. So we wanted to look at the whole model around that and how we could provide ready to use and what resources we could use from licensed and unlicensed for medicine preparation services sort of around the region. We had a discharge planning arm that Ewan was very much involved with. Most of the other Nightingale hospitals had been discharging patients back to the base hospital, and we wanted to look at, because of where our site was, it was quite sort of remote from any city centres. We wanted to look very much at looking at discharge planning to allow patients to go home to their homes or to the place that we're shielding at. So we wanted to do some work around that. And then we also wanted to sort of like look at how the clinical trials work, mental gas and governance. I'll try and cut this a bit short because I know I'm a bit short for time. But it's very much, we try to produce the full range of pharmacy services that you are probably all familiar with in your, your current organisations. So the next stage really was, right, we know what we want to achieve, we know what we want to develop. So we went to try and get some support from the regional hospitals and also linked organisations from the CCGs, from NHS England, from Health Education England. And we pulled in some great people, and we were allowed to use some great people from around the region. I'll sort of show you the picture at the end of all the people that were involved. And very much the way in which we managed this programme was to have those experts lead the work streams that I've listed above, to draw up and plan what we want to achieve and then execute that. And they went on again to use the people with skills in their own organisations to support that work development. And the way in which we manage it was very much do it every day. We had daily steering meetings where people would, update us on their actions, escalate the problems, and keep the programme rolling. So we keep up with the pace that we needed to do to deliver to that 3-week timeline. We did work with a programme management office on site, and there was a system by which all of the nursing leads, ancillary staff, security, distribution, logistics, all of those people were on site, and there was a daily stand-up meeting where everybody, again in the wider work streams, all came together, we did a half an hour, everybody updated where they were up to or who they needed to speak to within the teams across the site. And that was a very effective way of delivering this in a timely manner. So if you go to the next slide, please, Sarah. So what did we create? So we got the clinical pharmacy service supported by e-record, as you can see there. We got a great medicine supply chain in place, which by virtue of the use of the sort of the regional procurement specialist, Dave Cook, he helped us set that up, and also with the support of the local hospitals. And we did manage to get a plan in place for a 30-minute transport turnaround time between Newcastle Hospitals Trust. So if there was issues with medicine supply, we knew we could link into that supply chain, and that transport was actually set up to help with transport of blood samples and various things. So that was a very useful thing we were able to use. We set up a clinical trial service, which was very much to be managed through the existing trial service we have in Newcastle Hospital Trust service. We also had set up the plans for the ready to use and ready to administer preparation service for the nurses. This is very much a collaborative work, because we needed to get help from the licensed units and also the unlicensed units in the region, and they were very supportive in that. We also did some work with the national. Someone's put his hand up. Ewan, do you need to ask something?
Sorry, no, I was just going to say, just because we're running behind, Steph, really sorry.
Just flash through.
Okay, excellent, thank you.
I'll flash through. It's okay. So yeah, so we set up this IV preparation service, some of which was being supplied through the licensed and unlicensed units, and also by some work that we were going to do on site, and we will develop the SPS worksheets within our team to support both what we're doing at North East and across the country. So all the rest of it you can see there, and basically all of this was underpinned by a massive operating model activation plan that we set up. Next slide, please. So the specialist things that came out of it were the push supply model. We very much wanted to make IV products ready to use for the nursing staff, and we also wanted to put supply technicians on the wards with the clinical pharmacists to work in teams to make sure that all the medicines that were needed were there ready, rather than the nurses having to come to the pharmacy stores or move off the ward because infection risk, and also so they didn't compromise patient care. We looked at doing the smoother discharge model, where we could discharge patients straight to the community, and part of that was linking up with this new scheme of using the EPS that Jane alluded to earlier. And then when we had the workforce and training model, very much to try and minimise the impact onto, withdrawing staff from other hospitals, very much mindful that everybody was losing staff because of isolation or shielding issues during the COVID crisis. And then we'll get the last slide, please. I think it's the last one. Yes, right. So really, this was a massive project executed in a very short time frame. We had a brilliant team. I was really lucky to be able to use a team to make it possible. We had Anne Black, regional quality assurance pharmacist. We had Ewan, we had Waz, who did a brilliant piece on workforce and the planning and the engagement with all of the regional hospitals. We had Kay from the education side to look at all the training. We had technicians from research. We had the clinical pharmacist Nick Corkill, and really it was an amazing project to work with, and a great opportunity to work in such a free place for innovation. There was no normal financial constraints or process constraints. It was very much, we need to get this done. And really everybody throughout the programme, the team here were amazing, very generous in their spirit and very generous in the time that they gave. Everybody worked longer hours. Everybody was just, focused on making this hospital the best it could be. And thank you to everybody that was on that team. I'll leave it there because I know we're running out of time.
Thank you very much,
Thanks
Steph.
for listening.
Thanks, Steph. Yeah, it was a phenomenal achievement and really fantastic to work on. So thank you for that. Right, we'll rush on now to Robbie, who's the Director of Pharmacy and Member Experience at the RPS. It's great to have Robbie joining us. He's an excellent speaker, a very inspiring person. My own personal view, I think, is that the RPS has done a tremendous job supporting the profession throughout COVID. But perhaps more importantly than any of that, Robbie's put a tie on, especially for the occasion.
So even I can't manage to squeeze this presentation down into 5 minutes, and I can speak really fast. So the important bit of this presentation is towards the end. So I am going to whiz through the first couple of slides. So do bear with me because we will get on some really important stuff. Not that the beginning bit isn't important, but we started off at the RPS like everybody did, watching COVID come across the horizon like a slow mist. And then rapidly accelerating. I remember having conversations across the organisation 2 weeks before I went into lockdown thinking, right, we need to start thinking about this. And basically that was on a Thursday, Friday, and by Monday we had talked about evacuating our offices, moving into business continuity planning, and all of us working from home. Now that for an organisation like ours is no small feat, a complex organisation, lots of different bits, ranging from the work that I do supporting members to keeping things like Medicines Complete and BNF online. So like I said, the technical aspects of keeping the show on the road were no small feat, but that happened really well. So big tick, great success as we moved into business continuity. But what also happened is we woke up on the Monday morning thinking the world has changed for pharmacy as well. I think we'd come to a realization that over the weekend, as the news got progressively worse about the impact that COVID would have on our communities, on the country, then pharmacy and the pharmacy team were going to be central to delivering what was needed to keep people safe and to help the NHS's response to this crisis. Next slide, please. And as we moved from what was our business continuity plan into thinking we were going to work in a completely different way, we set up a program which involved all of our membership teams. So about 70 staff in all were taken out of their business as usual work and set up into a COVID-19 pandemic program with 4 key aims, as can be described here. But the overarching bit was to support our members in the profession to make sure that they were as equipped as possible to continue delivering high quality care to patients. But we knew during that we needed to keep our profession and the teams that they worked with safe. And you can see that was a core aspect of what we wanted to deliver through the programme. Next slide, please. And as part of the programme, we set up 5 projects within that with an overarching governance structure you'll see in a moment. But what this helped us do was move everyone out of, as I say, their business as usual and into a whole new way of working. So people were not only working from different places, usually their spare bedrooms, a bit like you can see, if you can see my thumbnail beneath the presentation, but also working in new teams with new team leaders and a whole new structure of work. Next slide, please. Now, the RPS has never been renowned for being fast and nimble. I am the first to hold up my hands for that, but we knew we needed to be different. We needed to set up a whole new reporting structure and escalation structure. And this happened overnight. Literally, we designed this on Monday and implemented it on Tuesday. And I want to say a huge thank you to all of my team who have really responded fantastically well to this. We did have a consideration as to whether we would put our pharmacists out onto the front line, but as many of our pharmacists, well, not quite as bad as I am, but are as out of practice with clinical aspects as I am, then it was felt that perhaps we would be more beneficial working on doing things once, doing them on behalf of the profession and rolling them out to help you and your teams in the work that you did. And I think that was probably the right decision. Next slide, please. Now, we asked our staff, our teams within the RPS, what they wanted to get out of this project. So apart from the program aims, they told us that they wanted to be agile, they wanted to be relevant to the profession, collaborative with other organisations, and Jane mentioned in her presentation earlier on some of how that had been delivered. We wanted to understand what was going on in the profession and be empathetic towards them, and we wanted to really advocate on behalf of the profession. Where the profession wasn't noticed, we wanted to make sure it was front and centre into people's minds. And I think we really delivered on that. We saw a mind shift in politicians, in senior policymakers, in their approach to pharmacy across the COVID emergency. It was really disappointing for us as a leadership organisation to see sometimes how forgotten pharmacy teams were, but we worked tirelessly alongside each and every one of you to make sure that we were recognised, be that from announcements by prime ministers to making sure you were at the front of the queue at Tesco's, recognising that each of those aspects, although small in their own considerations, build up a picture to keep you motivated and to make sure that your roles are respected and recognised. Next slide, please. So we delivered this on behalf of our teams, but we delivered those aspects that our teams wanted to do, but we also had some key indicators of what we wanted to deliver on behalf of the profession. And you can see some of the wins that we captured here, the metrics that we were tracking ourselves to deliver on behalf of you, our members, our profession, and the wider pharmacy family. We did things such as that ethical framework, a framework for pharmacy professionals to make ethical decisions under difficult circumstances, a document that many members of the profession, some people on this call as well, came together to support us in devising, and a document that would have taken 9 months, a year to deliver in a previous life, was delivered in 2 weeks, published, and really well received. And the mantra that we got throughout this, which is hard as a pharmacist, it's hard for our pharmacists in the team, was if it's 80% right, get it out there, because if it's 80% right, it will help. And if we wait for everything to be correct and spot on, then we'll slow ourselves down. And I think, alongside people on this call who have fed back to us, where things haven't been right, a huge thank you to the profession for recognising that and collaborating with us on producing some really helpful, I hope, resources. Next slide, please. And it can sometimes feel that you're in the eye of a storm, and sometimes you just need to lift yourself out of that to see if the work that you're doing has been impactful. I know all of you will have felt exactly the same. We're really thankful because we get immediate feedback. Where we've done something wrong, people immediately feed back to us, but often when we've done things right, people immediately feed back to us. The world of social media is a great avenue for that, and we were really pleased to see that during the COVID pandemic, the vast majority of members in the profession responded well and supported us in the attitude we've taken towards delivering on behalf of you all. However, next slide, please. This certainly isn't a celebration, and this isn't a celebratory talk. What we also discovered during COVID is things aren't great in our profession, things aren't great in our society. We had pharmacists, pharmacy team members across a range of settings die as a result of COVID. We had people we care for, friends and family affected by COVID. But what it did demonstrate to us, and we saw through the work that Public Health England have done, is that we, both as a profession and as a society, had some questions to answer. Next slide, please. So about 18 months ago, we had decided as a professional body to take on some work looking at equality and diversity and inclusion in our profession. I'd started a journey where I was really proud looking out at our profession, that the diversity that we had was fantastic. But then soon came to recognise that actually the picture isn't as rosy as you'd get just looking at a room full of pharmacists. I put out a blog around my experience as a gay man, as a pharmacist, and some of the experiences I'd had, and quite quickly received emails from other people who identified as gay, that their experiences hadn't been as positive as mine. And some of the stories that I heard were really upsetting. And also people from Black and Asian minority ethnic backgrounds soon came to talk to me and said that their experience of pharmacy wasn't as positive as mine had been, and race was a key aspect of that. And we heard stories from people who were disabled that actually pharmacy isn't a welcoming profession. The training, the fact that you've got to stand for long periods of time, the fact that neurodiversity isn't recognised as a positive trait in pharmacy meant that actually my initial concepts of thinking that this was a profession I was really proud of were changed, within days of me saying that. And now I think we can be proud in some ways of the diversity we have in our profession. I think compared to some professions, we've got good diversity, but we do not see that at all levels of our profession. We do not see that all people experience that. And so during our work, looking at inclusion and diversity in our profession, that has been explained to us loud and clear. And that is something that has definitely come out throughout COVID as well. We paused the launch of our inclusion and diversity strategy because of COVID. Now that was a decision that we took at the time. We needed to expend all of our efforts on supporting the profession. It probably wasn't the right decision to make, reflecting back, but in hindsight, with what we knew at the time, that was the decision we took. But rapidly, during the publication of outcomes through COVID, the impact it was having on Black, Asian and minority ethnic communities, the impact it was having on people with disabilities, meant that we had to quite quickly take an approach that was quite forceful with both government, with the NHS and with employers, that said we do need to do more to keep what is a huge proportion, over 40% of our proportion comes from a Black, Asian and minority ethnic background. We need to do more to be keeping all of our teams safe, but with a particular emphasis on those who we need to put extra mitigation on. Next slide, please. Just going back to the work that we did prior to COVID, we were pleased initially to see that nearly 2 out of 3 pharmacists considered this a welcoming profession, but then when you start to flip that on its head, that a third of pharmacists don't think we're a welcoming profession, and some examples of that are on the right hand side of the screen, then again it shows us that we have a lot of work to do. Myself as a leader, other leaders around me, but at all levels in the profession, we've got a tremendous amount of work to make sure that all members of the profession feel that they belong, feel that their differences are celebrated, and feel that this is a profession, a community that will keep them safe both now, during COVID particularly, but also in the future from health and other experiences that will be detrimental to their career, their professional development. Next slide, please. We spoke with hundreds of pharmacists, both members of the RPS and non-members of the RPS, during our work in building our inclusion and diversity strategy, and we were pleased to see that 83% of those people who responded felt that inclusion and diversity was an important topic for RPS to speak about, and we hope that even more people will get behind the work that we're starting on as an organisation, but that many people have been on for quite some time. Next slide, please. Our pledge, our strategic priorities as part of the work that we've done, from listening and working with the profession, that we co-created with stakeholders and engaging with, like I say, hundreds of pharmacists and pharmacy team members, is three-pronged. The first of all is that culture of belonging. Wherever you work in pharmacy, at whatever level you work at, be that student, pre-reg, foundation pharmacist, up to chief pharmacist and pharmacist, like I say, all levels of their career. This should be a profession that you feel you belong to, that you feel you have some. Sorry, bear with me a second. This is bath time, which is why I was so eager to get finished for 6:15. So you may well hear some children. Creating a sense of belonging, that people, like I say, have. Their differences are celebrated, their unique contribution to our profession from their background, from their experiences, is recognised and celebrated. On top of that, we need to make sure that not just all levels, but particularly our leadership, is more representative of the communities we serve and the profession that we serve. And we will be championing inclusive and authentic leadership throughout this work that we're doing. And we've been delighted to work with the UK Black Pharmacists Association on some pieces of work around that, but we will be building up a programme of work as we move through. And our third strategic priority is challenging inclusion and diversity barriers. We heard from, as I said earlier on, people who have a disability that this isn't a welcoming profession. And we've also seen, as Peter mentioned earlier on, the discrepancies that there are of people wanting to enter the profession, and that just isn't right and has been going on for far too long. Next slide, please. So we've been, as I say, working throughout COVID, despite the fact that we hadn't published our inclusion and diversity strategy by then, but we haven't been standing still. We've been doing work on behalf of the profession to make sure that some of the things that we'd heard about both before COVID and during COVID were being addressed at all levels. And we have had some success in that, but this is by far only the start of a journey. And I do hope that all of the people on this call, all of the people that you work with, the whole pharmacy family, and as I've said before, this isn't just about pharmacists, this is all of the people we work with, will get behind this as a key priority to making sure that the profession that we're all really proud of now is a profession that's even better, a profession that we can be even more proud of in future for pharmacists who are starting off in their career or have been in their career for quite some time. Next slide, please. So these are some of our next steps for 2020, and we are more than happy, in fact delighted, to be held to account on our delivery of these. We can get distracted by lots of new things, but we have committed to these and we are publicly committed to them for the reasons that I have just described. But you will be able to read those in some more detail by looking at the report. Please do Google RPS inclusion and diversity and you'll be able to download the full report. It is an interesting, a difficult read, but I do hope that by delivering on that we will have an inspirational profession for the future. Next slide, please. But on top of all this, you know, we want the profession to be a better place. We want the profession to be a place that people want to join in their droves. And we can only do that by people's experience of pharmacists, by people's experience of pharmacy teams. And we know that throughout COVID, the public's attitude, politicians' attitude, policymakers' attitudes, and healthcare professionals' attitudes to pharmacists and the teams that they work with has grown exponentially. Their expectations of pharmacists are more than they've ever been, and that's a great honour for us as a profession. So from us at the RPS, I've got a little message for you. Thank you all very much. You make us all very proud and make the work that we do at the Royal Pharmaceutical Society worthwhile. So keep on doing the great work and thank you for this afternoon.
Thanks, Robbie. That's much appreciated. You can go and kick the kids out of the bath and run one for yourself now. Thank you very much, Robbie. So thanks to all of our speakers. As I said, I don't think we've got time for the Q&A at the minute. We have run a bit over, but thank you so much to all of our speakers for making this a great event. It's really not easy to present virtually, but I think this will become normal for us. We'll all get more used to it. So thank you very much to the organising committee, particularly Sarah, who's been on hand to ensure all the technical stuff works. And also Laura Tweddle for marking the pre-reg project, as well as all the sponsors and supporters without whom this wouldn't have been possible. So, but most importantly, thank you to all of you for attending. I hope you've enjoyed it. I certainly have. So safe journey home, everybody. Thank you very much.